and good evening to all of you. It's my honor to be asked to speak to you about updates from the last meeting of the NKF this past spring. The meeting was held in New Orleans, Louisiana, and similar to this meeting, it had to go virtual because of COVID-19. But there were several hypertension topics of note that were discussed. And we're going to touch on aspects of all three of those. One includes blood pressure goal in patients with diabetes, and we'll talk about some of the shortcomings in the data in regard to patients with CKD and diabetes. We're going to talk about best practice of how to measure blood pressure. And then at the end, we'll touch on some therapeutic considerations of managing hypertension in patients with chronic kidney disease and show some of the newer data about some different medication. I'll just start by showing some classic data associating hypertension with endpoints in kidney disease. We'll talk about the current 2020 guidelines for blood pressure target in diabetes. We'll talk about different measurement techniques for blood pressure. And then the medicines I want to touch on will be the use of distal acting diuretics in chronic kidney disease, as well as SGL2 inhibitors in patients with chronic kidney disease. So nobody, I think, questions the value of blood pressure reduction, but what's become very important over the last 10 or 15 years is how low should blood pressure go. And that interest stems I think it's illustrated very nicely by these classic papers in medicine. This one on the left from the Lancet in the early 2000s, showing that at all age groups, the lower blood pressure is, the lower the mortality is from ischemic heart disease. And in the late 90s, in the Mr. Fit trial, it was demonstrated very clearly that higher blood pressures are associated with end-stage renal disease. And while these aren't new, they do illustrate nicely why there is so much ongoing focus on how low can we get blood pressure and what is the benefit. And with more recent data, it's very clear that persistent hypertension in chronic kidney disease is associated with events. And this is ambulatory blood pressure monitoring data from the CRIC study, which is the chronic renal insufficiency cohort. This is the largest prospectively followed cohort of chronic kidney disease. And what we can see is that in terms of cardiovascular outcome, kidney outcomes, or mortality, patients that have either masked or sustained hypertension in all of these categories are more likely to have cardiovascular, kidney, or fatal events. And if you look at a compilation of clinical trials performed over the years, and this is just a subset of trials, it's apparent that as we lower blood pressure, the decline in GFR goes down. And these are some of the earlier trials that were done. But where we are now is that trials that are targeting blood pressures between 130 and 140 don't necessarily seem to demonstrate the same reduction in loss of GFR that we're seeing at higher levels of blood pressure reduction. And so this has really formed now the center point of clinical trials, which is there benefit to lowering blood pressure much below 140, even though we know high blood pressure is associated with events. So these are the current guidelines from the American Diabetes Association for blood pressure targets in patients with diabetes. And these were published earlier this year in 2020. And they have two main categories. One is a blood pressure target of less than 130/80 if that individual has a high cardiovascular risk as defined by existing cardiovascular disease or a 10-year AHA/ACC risk score of greater than 15%. But this is a pretty weak recommendation, and it differs a bit from the recommendation in those folks who are at lower risk for cardiovascular disease, in which they only advocate for a blood pressure goal of 140/90. And this is a much stronger recommendation. And compare that to the AHA/ACC guidelines from 2017, which basically says everybody should be targeted to a goal of less than 130/80. Why does the Diabetes Association have different blood pressure goals for patients at different levels of cardiovascular risk. And part of the answer to that question comes from data shown in this meta-analysis. And what this shows is starting blood pressure in relationship to outcomes. So if patients started with a blood pressure greater than 140, we see that there is a reduction in the risk for end-stage kidney disease with lowering blood pressure. But if patients start with a blood pressure of less than 140, there's very little and perhaps no benefit to slowing of chronic kidney disease in patients who are starting with better controlled blood pressure. And if you look at some of the other metrics, such as coronary heart disease, cardiovascular disease in general, you see a similar relationship. Stroke is one of the few outcomes where further and further reduction in blood pressure, regardless of where you're starting from, may be beneficial. So based on this, the ADA, the American Diabetes Association, felt that if you were at lower cardiovascular risk, and in particular, if your starting blood pressure wasn't quite as high, there may not be benefit to further reduction in blood pressure. But what about the achieved blood pressure? So it seems as though starting antihypertensives at lower blood pressures may be less helpful. But what about the absolute level of achieved blood pressure? And that's what's shown here. Now, we know from SPRINT, which was non-diabetics, that the lower the blood pressure, the greater the reduction in cardiovascular events and mortality, but it had no impact on slowing the progression of chronic kidney disease. And so when you look again at a meta-analysis of trials in patients with diabetes, we find that when you achieve a blood pressure greater than 130, which could be 130 to 140, there is a reduction perhaps in the slowing of chronic kidney disease. But when you lower blood pressure below 130, and keep in mind that SPRINT and ACCORD were targeting blood pressures closer to 120, when you go below 130, at least in a meta-analysis, you seem to lose that protective benefit on chronic kidney disease progression. There's still a reduction in albuminuria, there's still a reduction in stroke, but some of these benefits in coronary heart disease and cardiovascular disease may start to disappear in patients with diabetes when blood pressure is reduced to less than 130. Now, it's important to recognize we don't really have well-powered randomized controlled trials of target blood pressure in patients with both diabetes and chronic kidney disease. The ABCD trial, which was published in the 90s, is maybe one exception, but we really don't have good data specifically in patients with chronic kidney disease. So the ACCORD study was the largest trial of intensive blood pressure control in diabetes, although it had very few patients with chronic kidney disease. And it was structured such that patients were randomized to intensive or less intensive glycemic control, less than 6 or between 7 and 7.9%. And then they were also randomized to a blood pressure of less than 120 or less than 140. And the primary outcome was cardiovascular. And this was the enrollment criteria. You had to be over 40 and you had to have a blood pressure greater than 130. And in general, the creatinine was less than 1.5. And this was the primary outcome of ACCORD blood pressure. So we're looking at the blood pressure outcome. And patients randomized to intensive blood pressure of less than 120 did not have a difference in their cardiovascular outcomes as those randomized to less than 140. But what was interesting is if you stratified the results by level of glucose control and level of blood pressure control, in fact, there were fewer cardiovascular events in the low blood pressure group if they were randomized to a hemoglobin A1C of 7 to 7.9%. There may be harm or at least no benefit to intensive blood pressure control when the glucose is also lowered to very low levels. This suggests that there may be blood pressure benefits to aggressive lowering in diabetes as long as we don't make the glucose too low. So Bedu and colleagues recently published a comparison of SPRINT to the outcomes of the ACCORD trial. And as we all know, SPRINT lowered the risk by about 25% or so for cardiovascular events with intensive blood pressure reduction. And in ACCORD, there was a very similar reduction with intensive blood pressure control as long as the glucose was maintained in a range of 7 to 7.9%. But if it was an intensive glycemic arm, then the benefits to blood pressure reduction were lost. And if you combine both groups, it does appear that over time, several years after randomization, there may be that benefit to low blood pressure. So what's important here is many times folks have interpreted ACCORD as not showing benefit to intensive blood pressure control, but it does appear that the benefits are very similar to what was seen in non-diabetics for reduction of cardiovascular outcomes, as long as the standard glycemia targets are maintained. But what about kidney outcomes with intensive blood pressure reduction? So this was looked at in the follow-up study to ACCORD called Accordion, and they looked at patients randomized to intensive versus less intensive blood pressure control. And the outcome here was a composite kidney outcome, which was incident albuminuria over 300 milligrams per gram, doubling of creatinine, self-reported dialysis, or mortality. And what we saw over time was that patients randomized to intensive blood pressure control were more likely to have an increase or more likely to have a composite outcome. And this was driven mostly by doubling of creatinine. So the lower the blood pressure goal, the more likely patients in ACCORD were to double their creatinine over time. And so if we compare this to the SPRINT study, there were very similar findings in both diabetics and non-diabetics. So green is the standard blood pressure arm of SPRINT, looking at the development of incident chronic kidney disease over time. This blue line is the intensive blood pressure control arm in SPRINT. So in non-diabetics, lower blood pressure goals were associated with a higher incidence of developing chronic kidney disease. This is the low blood pressure arm, or the standard blood pressure arm in purple of ACCORD, and in red is the intensive blood pressure arm of ACCORD. And very similar to SPRINT, in diabetics in ACCORD, the lower the blood pressure target, the more likely participants were to be diagnosed with incident chronic kidney disease. And if we look at the decline in GFR over time, this is the standard arm in ACCORD, and then red is the intensive blood pressure control arm in ACCORD. And we see that there's a very prompt drop in GFR, but eventually the slopes do seem to be very similar. So while there is a decline in GFR in the intensive blood pressure arm in ACCORD, it does seem as though the rate of further decline may be similar between the two groups. So we know that intensive blood pressure control in SPRINT and in ACCORD is associated with increase in creatinine over time, and patients are then diagnosed with chronic kidney disease. But the issue is whether this is a hemodynamic change or whether there is true structural injury to the kidneys with blood pressure reduction. And so investigators took participants from ACCORD, looked at the intensive blood pressure arm compared to the standard blood pressure arm. And what they found was that GFR went down about 11%, albuminuria went down about 30%, but there was no increase. In fact, there's either a decrease or no significant change in injury markers, biomarkers of kidney injury. So this has been shown in non-diabetics in SPRINT as well, but it appears that intensive blood pressure reduction does lower GFR. It does not associate with markers of kidney injury. And so the chronic kidney disease that patients with lower blood pressure have been shown to develop may simply reflect hemodynamic perfusion changes and not necessarily true injury to the kidneys. So we know that intensive blood pressure reduction raises creatinine or lowers GFR. But I want to remind us, and this is taken from another meta-analysis, that achieving lower and lower blood pressure in diabetics has not been associated with a consistent reduction in the risk of end-stage kidney disease. So there may not be true structural injury to the kidneys with blood pressure reduction, but at the same time, that blood pressure reduction is not necessarily slowing the rate of progression to end-stage kidney disease. It does seem to lower cardiovascular events, but this analysis shown here, which took data from NHANES, which is a national study in the United States, as well as the Diabetes Heart Study, suggested there may be a U-shaped or J-shaped curve for the risk of cardiovascular events in diabetics. So while lowering blood pressure may be helpful to reduce cardiovascular events, some data suggest that if we get much below 120 to 135, the risk for cardiovascular events may then start to increase again. So there may be a bottom threshold below which we really do not want to lower blood pressure in diabetics without increasing the risk for cardiovascular disease. So to summarize current blood pressure goals in diabetes, it's evident that lowering blood pressure to less than 130, targeting 120, does reduce albuminuria, and it reduces progression to incident albuminuria. It seems to reduce cardiovascular events as long as you maintain a glycemic control above 7. But if you go to a blood pressure below 120, there may be an increase in cardiovascular events. And it appears that intensive blood pressure control does increase the creatinine, it lowers GFR, but it may not be associated with true structural injury. But at the same time, we don't have compelling data that we are slowing progression to end-stage kidney disease. So based on this, the American Diabetes Association has recommended targeting around 130/80 for individuals that are at high cardiovascular risk, mostly to lower their cardiovascular event rate, not necessarily to slow progression to end-stage kidney disease. But if they are at lower cardiovascular risk, to target a slightly higher blood pressure goal, given the lack of data showing robust outcomes in patients who are starting at less risk or lower blood pressure. So I'd like to switch and discuss another topic from the NKF meetings, which is best practice in measuring blood pressure.
Next slide, please.
So we know very clearly that measuring blood pressure in the office may induce a white coat effect. And so there is a big push now for using what is called AOBP, or automated office blood pressure, which I will describe, which is an average of 3 measurements with the patient by themselves in a quiet room, done with a device that runs automatically. So anytime we are doing blood pressure, we need to be very attentive to proper technique. Patients need to have their feet flat on the floor, their back supported, their arms supported. They should be resting for at least 5 minutes. And then we should take the average of those 3 seated blood pressures. And during that time, participants or patients should not be talking. They should not be on their phone. They should not be reading. They should simply be sitting there quietly. So this is the AOBP device used in both Sprint and Accord. And this is different than an automatic blood pressure machine that all of us use frequently in the clinics. This device is configured to run by itself. And so it's applied to the patient's arm. The patient is placed in a room by themselves, and the machine will give them a period of 3 to 5 minutes of rest. And then it will automatically take 3 blood pressures and average them for you. So why is AOBP so important? Well, these 2 figures show the relationship of blood pressure measurements from AOBP to either research quality manual blood pressures or standard routine office blood pressures. So if you measure a manual blood pressure as carefully as you would do for a clinical trial, AOBP is still on average around 7 millimeters of mercury lower. There's still a white coat component when you are measuring blood pressure manually. And if you compare AOBP to a standard office measurement, where maybe the nurse just puts an automatic cuff on the patient, or the blood pressure is done very quickly and not very carefully, AOBP may be 14 millimeters of mercury on average lower than what you would traditionally measure on an office blood pressure. So many people would consider 24-hour ambulatory blood pressure monitoring to be the gold standard, but it's obviously difficult to obtain. So in a meta-analysis of many different studies, AOBP was virtually identical to the awake systolic blood pressure from ambulatory blood pressure monitoring. So if you can't get a 24-hour blood pressure study, AOBP is essentially equivalent to the daytime awake values from ambulatory blood pressure studies. But what about AOBP in patients with chronic kidney disease? We don't, to my knowledge, have good data on AOBP versus 24-hour ambulatory blood pressure data. But in this study here, they looked at participants who would have been either in SPRINT or in CRIC, which is the chronic renal insufficiency cohort. And they found reasonably good correlation between AOBP and manual blood pressures. So with an average GFR of 41, AOBP was about 5 millimeters of mercury higher than a manual systolic blood pressure, and diastolics were about the same. AOBP was about 0.2 millimeters of mercury lower. So AOBP is similar, if not a little bit higher actually, to in-office measured systolic blood pressure in patients with chronic kidney disease. Part of the reason AOBP is so important is this is how it was used. This is how blood pressure was taken in SPRINT and in ACCORD. And recall from the slides we just saw that AOBP may be 5 to 20 millimeters of mercury lower than a manual in-office blood pressure. It may be 5 to 7 millimeters of mercury lower than a research grade manual in-office blood pressure. And there are data, this comes from a hypertension clinic at Harvard, there are data that awake ambulatory blood pressure from 24-hour blood pressure studies correlates much better to AOBP than it does to the in-office blood pressure measurement. So if you are trying to target blood pressure goals from SPRINT and ACCORD, recognize that the office blood pressure you are measuring may be anywhere from 5 to 20 millimeters of mercury higher than what you would have gotten with AOBP, which is how they measured it in the trials. So if you have an office blood pressure of 140 and you're trying to get to 120, if you're not using AOBP, you may already be at 120 if your manual in-office pressure is overestimating what their true blood pressure really is. And now you are at risk for making patients hypotensive outside of the office. So in the real world, AOBP may lead to more accurate values being recorded, and it may also save you a little bit of time in the office. So this looks at pre-AOBP. So these would be traditional blood pressure measurements, systolic and diastolic. And as we well know, a lot of patients have blood pressures of 130, they have blood pressures of 120, they have blood pressures of 110, right? Their diastolics are 90 or they are 80. People taking blood pressures have a tendency to record the number that they want to see. But when you put patients on an automatic monitor like AOBP, we see that the curves are much smaller and there's no longer this human preference for certain blood pressure targets. So we are more likely to have an accurate representation of blood pressure. In addition, if you can trust your blood pressure measurements, you don't necessarily need to repeat them yourself. And so what they looked at here was the frequency at which the physician might have to repeat the blood pressure taken by the nurse. And before AOBP, it was around 20 to 30% of the time the physician felt compelled to recheck the blood pressure. After implementing AOBP, there was about a 15 to 20% reduction in the number of times physicians had to repeat the blood pressure because it was felt that the measurements obtained by AOBP were much more accurate. So I'd like to shift to the last topic that was focused on at the NKF meeting and look at some more recent data on treatment considerations, drug considerations in patients with chronic kidney disease.
Next slide.
So this looks at dietary sodium intake in individuals around the world. And the American Heart Association recommends a 1.5 gram per day sodium intake. The World Health Organization, a little bit higher, around 2 grams. This arrow should be moved over. Around closer to 4 grams per day is the typical sodium intake of our chronic kidney disease patients, well above those recommendations from the different international organizations. And here's the average daily sodium intake for individuals in China, which is closer to about 5 grams per day. So this trial was published earlier this year, and it was trying to answer the question of whether distal diuretics work in patients with chronic kidney disease. And I think for many years, we have been taught, and we have taught others, that thiazide and distal acting diuretics are less efficacious in patients with chronic kidney disease. So it's known that dietary sodium lowers blood pressure, dietary sodium restriction lowers blood pressure. We often think distal diuretics are less effective than loop diuretics. So what this trial tried to do was see the effect of dietary sodium restriction versus a distal diuretic like hydrochlorothiazide. So patients had a run-in period. They are randomized to amiloride and hydrochlorothiazide versus dietary sodium restriction. They had a washout period, and then they were back. Then they switched, and they were on amiloride or they were on sodium restriction. So here were the characteristics. Patients on average were 21 years old, 65% men, 20% had diabetes, and the average GFR was 39 with 145 milligrams per gram of albuminuria. So what happened? Well, this looks at sodium restriction versus participants on diuretics, looking at urinary sodium excretion. So when participants had sodium restriction in their diet, we see that urine sodium excretion goes down, showing that participants, in fact, were adherent. On diuretics, we see no change in urine sodium. And this is what you would expect. In a steady state, the amount that you take in should be what you excrete. And so the urine sodium should be the same as long as they did not reduce their dietary intake. So this shows that when on dietary restriction, they lowered their sodium intake. And when participants were taking diuretics, they were on a constant, unchanged dietary sodium intake. This is looking at change in GFR. There is a slight reduction in GFR with sodium restriction that goes back to normal when they washed out. And on diuretics, there was a greater drop in GFR that also goes back to normal when the diuretic was stopped. And this looks at mean 24-hour systolic blood pressure. And there was a reduction of about 5 millimeters of mercury with simply limiting dietary sodium intake. But there was a reduction of 14 millimeters of mercury in participants randomized to distal acting diuretics, which we have often thought are less efficacious. As you might expect, but it still worked, the clearance of diuretics was lower for hydrochlorothiazide and for amiloride at lower GFRs. So at lower GFRs, there was less delivery of diuretic into the kidney. Nevertheless, the reduction in blood pressure was still achieved. And so in participants with low GFRs, there was still a significant reduction in 24-hour systolic blood pressure. There was still a significant reduction in body weight. So even at the low GFRs, because some of these participants had GFRs above 60, but even in the low GFRs, there was still a nice reduction in blood pressure as well as body weight, demonstrating that the diuretics, in fact, do work. And then I want to finish up with some discussion of SGLT2 inhibitors in patients with diabetes in hypertension. So as you probably know, most of the SGLT2 inhibitor trials have been done in patients at high cardiovascular risk, and blood pressure has not necessarily been the primary outcome. So investigators have had to pull data from multiple different studies. So this is a collection of 11 trials in patients with advanced chronic kidney disease, stage 3B to 4, and diabetes, 66 years old. Most had GFRs between 30 and 45, and they were on dapagliflozin. And what you can see, if we look at the average blood pressure reduction, is that in green at 10 milligrams, there's about a 6 millimeter reduction in blood pressure. On 5 milligrams of dapagliflozin, it was about 3 millimeters of blood pressure reduction, compared to a little bit less than 2 millimeters in patients on placebo. So even in individuals with more advanced chronic kidney disease, there does appear to be a small blood pressure reduction in patients taking SGLT2 inhibitors, and in this case, dapagliflozin. And these are data for another inhibitor, empagliflozin, which was pulling 5 different trials. And this is stratified by GFR and reduction in blood pressure. And you can see that as GFR goes down from 90 to less than 30, there is a preserved, and in fact, maybe even a greater blood pressure reduction in patients with advancing chronic kidney disease, both systolic and diastolic, who are given empagliflozin. So we don't fully understand why SGLT2 inhibitors reduce blood pressure. Some of it may be natriuresis, but as you get to much lower GFRs, that natriuretic effect is likely minimal, and yet the blood pressure reduction may be increasing. So some of the other leading theories suggest that SGLT2 inhibitors decrease sympathetic tone. At least in maybe some individuals, there'll be a weight loss associated with it. These inhibitors may potentiate nitric oxide synthesis and vasodilation, and they may reduce some oxidative stress. We don't really know for sure how they were lowering blood pressure, but the sympathetic tone may be one of those more important reasons. And when you combine it with different agents, there may be a slightly different blood pressure effect, and you get a little bit more blood pressure reduction when you combine it with a RAS inhibitor and a dihydropyridine, such as amlodipine or nifedipine, than if you combine it with a RAS inhibitor and a diuretic. But the recommendations are not to stop a diuretic when you add it to advanced stage CKD, because that natriuretic effect likely is fairly minimal at these lower GFRs. So essentially, we just add it to participants or add it to patients, typically with GFRs that are around 30 or above. So in summary, we've known for many years that uncontrolled hypertension is associated with higher cardiovascular and kidney events. The question, though, becomes whether aggressive reduction really lowers those event rates. It does seem that in diabetics, targeting blood pressure closer to 120 reduces cardiovascular events as long as participants have a standard glycemic target, that we're not targeting very low levels of hemoglobin A1C. But these lower blood pressure targets are associated with an increase in creatinine that may not reflect structural injury to the kidneys. Yet at the same time, lowering blood pressure below 130 does not clearly slow progression to end-stage kidney disease. We need to be very thoughtful about how we measure blood pressure. The recommendation is to use AOBP whenever possible in the office. And if you can obtain out-of-office measurements, such as with a 24-hour ambulatory study, both of those are superior to a regularly measured blood pressure in the office. And from a therapeutic perspective, consider that thiazide diuretics are much more effective at controlling blood pressure than our loop diuretics. And the traditional teaching that we should switch patients with chronic kidney disease from a loop diuretic to a thiazide diuretic may not be correct. And in fact, thiazide diuretics are efficacious at lower GFRs. And now with the advent of SGLT2 inhibitors, we ought to be looking to get our patients on these as much as possible. They have benefits in slowing CKD progression, but they may also be effective antihypertensives when added to other regimens. So thank you very much. It's been a pleasure speaking with you. I enjoyed meeting many folks last year in person, and I hope that maybe in 2021 we'll get to meet in person again. Thank you.